You should be very clear about why you are referring, where you are referring, how you are referring, and what components you should include in your referrals. Every patient should not be referred, and every patient should not be dealt by you. You should know your boundaries. You should know your clear-cut ideas of what to do, what not to do. So if you take a proper referral, first is defining of the referral, that why you want to get this patient referred. The elements of the referral letter, if you are referring a letter, what elements you should include in the referrals, and the general reasons, this is why you are referring. Factors that can increase or decrease the referral area. Monitoring of the referrals. Then you also need to monitor, if I referred this patient so and so to that specialty, what happened to him. So you also need to monitor that. Definition of the referral is, if you are not sure, what are the different reasons you are going to refer the patient? Some words from you guys. What are the reasons that you refer? Yeah? Investigations. You want a referral for investigation.
You don't know the problem, so you want a consultation.
So you're not sure about the condition, or for the better diagnosis? For the better diagnosis.
The disease actually is beyond
The disease beyond your scope. For the different speciality, yes. Interventions, okay, for further interventions. No facilities, because of lack of resources, you don't have it. Out of the scope. Complicated, rare cases, yes. For operations, yes. So this is how you're going to. These are the reasons that you're going to refer the patient. So it's very important why you are referring the patient. You should know as a physician why you are referring. Okay, if you are creating a referral letter, a referral letter should have what things? Name, obviously, medical record if present, age, address, then the presenting complaint. Patient presented to me with this problem. We have done this, or hospital course, you can say. History of presenting complaint may include also the hospital course, some past medical history if it is required, medications up till now, some social background if it is relevant. So these are all relevant things you can put into your referral letter, that I have done this already, and I am concerned about this problem. I am concerned about investigation. I am concerned about the diagnosis. Am I going in the right direction or not? Things like that. Most of the times, the referred doctor doesn't know why the patient is being referred, and the patient doesn't know why am I being referred. So how can we treat the patient? Allergies, some physical examinations, investigations done, your diagnosis, your working diagnosis, and the reason for referral, and a specific information or the service needed from that specialty. For instance, you wanted to get some MRI done, you wanted to get some CT scan done. This is why you are referring the patient, not for the diagnosis. Sometimes you want a proper diagnosis, sometimes you want to reassure the diagnosis. Things like that, these are all comes in the reasons for referral. So if I would like to draw the structure of the referral criteria, the element is first the demographic data or identification tool, name, address, age, then presenting complaint, the patient presented to us with this problem. Then in the hospital course or the OPD course or the clinical course, which includes presenting complaint, history of presenting complaint, past medical history, the labs done, working diagnosis, this all will come into maybe the hospital course or the patient clinical data. And then the reason for referral. Reason for referral could be diagnosis, could be investigation, could be service needed from that hospital or from that consultant. General reasons we discussed: for the diagnosis, for the investigations, for a special treatment, for operations, for maybe taking over. So he was a diabetic and hypertensive patient, and we are planning to have a hip replacement or a knee replacement, but his sugars were not controlled. So orthopedic referred to you to control his sugar, and then you should come back. So now it's taking over. Now you as physician, you have controlled the diabetes and hypertension. Now you are referring back to the patient to the orthopedic, and then they can do their own things. So sometimes only the reassurance of the patient. Patient wants a referral. They are not satisfied with you, or they want a specialist opinion. You can do that, but that needs to be done on a very genuine reasons, not just that I need a referral for this problems, I had to take a referral. For reassurance of the doctor, as a physician, you are not pretty comfortable of diagnosing some problems, and you want a specialist input into this, you can take it. Over or under referrals, incorrect labeling, collusion of anatomies, that means that you are not referring the patient because this patient is actually giving you revenue, and you do not want this patient to go away from your specialty. So these kind of things could also restrict you from referring. Somatic fixations, de-skilling of the GP. So if the GP is not very skilled on the problems that he is facing, although it is coming under their scope, but depends on your own training, your own clinical knowledge, it can make referrals increased or decreased, and de-skilling of the specialists. If you do not have a rheumatologist here in your community or something like that, you cannot easily refer the patient because it's going to be very difficult for the patient to being referred. Sometimes the patient deprive of the patients of benefits, deterioration conditions, lost touch with medical developments. So these are all reasons where there is an inappropriate referral. Factors we have discussed, doctor's factors. Sometimes the doctor is not medically equipped, sometimes the doctor is not medically updated, and that's the reason they refer the patient. Patient factors, sometimes the patient wants it, sometimes the patient reassurance, sometimes the relatives wants it, and things like that. Systemic factors, you can address the issue, but the system allows you to, you cannot, the system says that okay, newly diabetic patient should be referred to an endocrinologist first and then can be managed with the family physician. So this is because of the protocols. The protocol says that. And the rest of the other factors, the financial issues, sometimes there are financial issues attached to it. Patient cannot go to the specialist and he wants you to treat this condition. So you can say, okay, ideally speaking, you need this condition needs a referral, but I'm a doctor, I can take this if you want me to. Because of the financial problems, you are a competent doctor, you can learn, you can see things and then manage the things accordingly. This is how you can do it, but patient's involvement is very important in those factors. So financial issues, availability issues, timing issues, transportation issues, that can also be incompetent with the referral that you are doing. The important thing is monitoring the referral. What is an appropriate referral rate, the feedback, other forms of the referrals. Monitoring is very important. Okay, I referred the patient, but what happened to him? Obviously the specialist is not going to give you a call and then say that okay, you referred this patient to me and I've done this. So you may want to follow this patient up with the consultant or with the patient. It's going to give you a good insight that was my referral appropriate or not? Did the patient get benefited with this or not? Sometimes it also happens, it backfires. You refer the patient for something to someone and the consultant was very angry that why did the hell you referred this patient to me? This is not my case. So this can also happen. So you need to be very careful on that you're doing a referral on appropriate reasons why you want to do it. And it's because they do not mention the reason for referral. They just mention that okay, the patient has this and I referred for further evaluation. Further evaluation doesn't lead to the consultant anywhere. What further evaluation you want? Further test, further diagnosis, what is your question? So if you do these vague referrals, it's going to harm the patient and angry the other consultant also, and waste the resources. So the proper feedback will give you the proper referrals that okay, doctor, you have referred me to that doctor. He was not very careful with me, and he did not manage the way I was expecting it to be managed. So you need to be very careful that okay, next time I don't choose this urologist or nephrologist. I may choose another urologist or nephrologist or neurologist or whatever, because I'm not getting not very good feedback from the patient. So that's very important. The feedback is very important. Monitoring is very important. And the referral criteria, we mentioned that the referral letter elements that are there. So you should be able to formulate a referral letter of any condition, of any problem, okay, with these tools that is mentioned here. So now we talk about the conditions. Just common conditions. There is a term called referral, and there is a term called danger signs. Any condition with the danger signs, you need a referral. Danger signs means if a problem has something that needs further evaluation, it's fishy, it's dangerous, maybe malignant, maybe resistant, things like that, and that needs every condition. It's a specific condition based criterias. You need to decide that now this patient needs referral. It's not my case, it's out of my scope. So you need to be very careful what is your scope, and what are the things that are mentioned here should not be dealt by a family physician. It should be dealt by a consultant. So it would be at your part, it would be a responsibility of you as a physician that you should refer this patient. If you are treating this patient, that means you are doing unfair to the patient and to yourself also. So let's discuss some of the specific conditions. Cough. Cough is a simple thing. You do presenting complaint, history of presenting complaint, and analysis, whether this cough is cardiovascular or respiratory, all that. You have done all this. But now I'm talking about when do you want this cough to be referred? You can manage as a family physician. Cough is not a referring criteria, isn't it? But if you're referring the patient, on what basis you should refer? If there is blood, weight loss, fever. Cough with fever is, why do you want a referral? So what? Any pneumonia is there, okay, so what? You cannot treat it as a family physician? When? In pneumonia, when do you want to refer? Failed treatment. Number one, failed treatment, yes. If it needs hospital admission, so you have gone through curve 65. If the patient has cough, fever is not a referring criteria, but with confusion, with increased respiratory rate, with vitally unstable, altered mental state of consciousness, obviously you need a referral. That needs so pneumonia with admitting criteria will need referral. Yes. Anything else? Yes. Not responding to the treatment, chronic cough going on. Choking, yes. But develop some acute signs of cyanosis and all that. Complicated fever, okay. With blood, okay. Yes, you want to get these things checked up. So cough is a very, starting with the basic problem, just upper respiratory tract infection, goes up to the malignancy. Okay. So you should consider these factors as you mentioned. These are called danger signs. So if these danger signs are there, you have to seek a referral. You cannot manage at your own. So one example is cough. I'm just giving you the examples to build up on this. whenever you are making your presentations with the conditions, whatever is the condition, you should need to mention your danger criteria so that we can have a consensus on that. Tonsillitis, simple thing, sore throat. Why do you need a referral? Complicated by abscess. Recurrence, huh? Grade 3 or 4 needs a removal. Duration, if it is getting very prolonged, huh? Shock? Maybe, yes, for sure. Yani tonsillitis leading to a shock, although it's very rare, but yes, you need a referral. But we are talking about that referrals which doesn't, yani if the patient is coming to you again and again, 5 times a week, you have done your ENT, right? ENT rotation is done. So what is the referral criteria for, what is the indication for tonsillectomy?
7 times per year, or 5 times per year, or 3 times per 3 years.
Yes. So if the patient, usually the lot of GPs are seeing your patients regularly, they don't consider that okay, it's been like 5 times or 6 times a year, and she should get a referral because she should maybe a candidate for tonsillectomy. They just, because why? Because the GP, it comes to the GP gives some medications and she was all right. Some medications with antibiotics, she was all right. Then after 2 months she came back. Then after 3 months she came back. But if the GP is aware that this condition is going to give this rheumatic heart disease problem, and she is actually meeting the criteria, she should get referral even though she is getting treated. So that's how a GP physician, if he has a good knowledge, what is the criteria for referring criteria for this, it has to be there. Yes, anything else with the tonsillitis? If there is unitonsillar enlargement, so that can also give you some hint. If there is a respiratory problems with the tonsillitis, where grade 3 and 4 we were talking about for the tonsillectomy. So these are all things that you need to be very vigilant with these benign conditions. Conditions like this, there are a lot of other conditions. Dyspepsia, very simple. You understand dyspepsia, right? Okay. What should be the referral criteria for dyspepsia? Associated with constipation? Chronic constipation. Why? If you're thinking like that, yes. Difficulty in swallowing. So dyspepsia with dysphagia. Weight loss. Old age. Smoker. Intractable vomitings. Yes, girls. Weight loss. Yes. Patient is smoker. Weight loss. Yes. Abdominal mass for sure. Yes. Females. Anemia, yes, that's a very occult sign. Dyspepsia with anemia, although responding to it, you had to refer the patient, yes. Not responding to the treatment for sure. A general tip or a rule. Referral criteria fits any condition. Obviously weight loss can fit with every condition, alright? Weight loss. Not responding to the treatment. So these are extreme of ages, dyspepsia in older ages, dyspepsia with the pediatric age group, you need to refer the patient. So extreme of age, these are general rules. Extreme of ages, weight loss, not responding to the treatment, it fits with every condition, alright? And then the specific things like dyspepsia with anemia is a very good sign. Because why? And it is very dangerous because a lot of physicians does not correlate dyspepsia with anemia. And dyspepsia with anemia is a very reliable sign for impending malignancies, gastric malignancies. some virtual varicose lymph nodes are there. That is also a very good sign for alarming that the patient may have some GI carcinomas. Lower back pain. Very simple thing. Everyone has the lower back pain. Okay. Why would you need a referral? Can you speak with the mic louder? Lower back with numbness and tingling. Yes. Why? Yes. So nerve compression, radiculopathies. That's great. Urinary incontinence. Quality of life. If it is affecting the quality of life, lower back is going to affect the quality of life, but you can deal it if there are no danger signs attached to it. And just affecting the quality of life is going to. Yes, but you need to treat this. If it is just a musculoskeletal problem, and that's why he's not going to the gym, so you can give some muscle relaxants and improve the quality of life. Actually, improving the quality of life is the prime responsibility of the family physician to intervene in a way. But with these problems, additive to that, you need a referral. Huh? Old age, lower back pain. Good. Fall. History of fall, trauma, acute lower back pain. Yes, needs to get some rest. Yeah. Urinary retention, urinary incontinence, urinary retention. Numbness, paresthesia. Yes. Yes. Limb ischemia for sure. Yes. Not responding to the treatment. Yeah. So, while you are managing the patient with lower back pain can start it off with the musculoskeletal problems and goes up to the malignancy. We talked about symptoms of saddle anesthesia, like saddle anesthesia, urinary incontinence, cauda equina syndrome, compression syndromes, and things like that. The symptoms that you guys have mentioned is actually pointing towards those problems with the lower back pain. So you need to be very careful what kind of lower back pain you are managing. If you're trying to manage these kind of lower back pains with numbness, paresthesias, paraplegias, this is then it should be your responsibility that you should get a referral for an orthopedic or a neurosurgeon with this thing. So there is another thing. While you are managing your patient, we talk about danger signs. If you are managing a patient, it also says in the consultation skill, there is a patient encounter. You're writing, okay, the patient has presenting complaint this. You do some examination, and then you also do a term called safety netting. Safety netting is you are managing the patient, and you says that doctor, the patient, or you, because you need to document so that it's not going to lawfully, the patient or the organization is not going to restrict you or caught you with some things. So safety netting is the patient does not have this, does not have numbness, does not have urinary stool incontinence. So you specify all these negatives, which we call important negatives, and then you manage that. Okay, now I can say that the working diagnosis is musculoskeletal lower back pain at this moment of time. Later on, if the patient comes to you or sue you for some reason that I was giving the medication with this doctor and this doctor does not treat me well, so you have a justification, clinical justification that you did not have these problems. Why should you need referral and things like that. So this is called safety netting. We will go into details when we discuss about history taking. Developmental milestones. The child is 8 months, 9 months old, not able to sit. You need a referral. If the child has hand preferences after 6 months, you need a referral. So these are occult signs you can pick up. If the child is not able to, newborn is not able to fix his eyes on the light, that's a referral. Why? the child is not able to fix his eyes into a spot of light and is just wandering right and left, his eyes is not able to fix. Facial? Vision problem? Vision problem? Yes, obviously vision problem, but what is the problem? Congenital cataract. So the patient, if you do examination and the red reflex is absent, are you aware of the red reflex? Yes. If the red reflex is absent, you need a referral. There is a called developmental dysplasia of the hip joint. You do a click, and if this click is present, you need to refer this newborn. So things like that, you need to see whether this patient needs a referral, because if you do an appropriate and urgent referral, it's going to impact on the prognosis. The problem is the patient ends up in a pediatric or a specialist clinic when the disease is already gone so far away. And because we as physicians doesn't realize the importance of early diagnosis and prevention, we miss these things. And when we miss these things, I talked about developmental dysplasia of the hip joint. The patient presented in 6 years old, 4 years old, 5 years old, he is limping because I miss, as a physician or as a pediatrician, the developmental dysplasia of the hip joint in the early stages. So that's the importance to diagnose all these problems earlier so that you can manage. Ear pains, same thing, not responding. Ear pain or otitis media or otitis externa is not the referral criteria, by the way. Family physician should treat otitis media, otitis externa and all that. But atypical presentations, extremes of ages, perforation with the unsafe area, there is a safe area or unsafe area. So you do that, weight loss, things like that is going to give you the referral criteria to the ENT. Why do you want an ENT referral? Otitis media per se is not a referral criteria. So these are some of the conditions that we discussed just to give you an idea or a tool that this is how you should think of. While you're doing your history taking in the primary healthcare, I would be more interested in mentioning these danger signs, whether they are present, not present. If you want to treat here, why do you want to treat here? Because doctor, he does not have this, that is why I want to treat here. I want a referral from her. Why do you want a referral? Because I see that this is a problem and I need a specialist opinion for this condition. So things like that. Danger signs, safety netting, you need to know the referral criteria, when I should refer the patient based on your clinical skills, based on your knowledge. This is going to identify your limitations as a family physician. All right? So best of luck. We are concluding the sessions of today's all the sessions, and try to go and look up these referral criteria and try to orient yourself as a family physician, and inshallah we will discuss it tomorrow for some of the communication skills lectures. All right? All right. Good. Thank you.